Morning, folks. I'm just enabling it so that the chat is available to everybody, as we had a little bit of an issue in that last little session. So hopefully that means that you can now interact when we have Laura with us. Laura, I can see you're in the main session. Let me just bring you in.
Hi, Hannah.
Fabulous. Hi, Laura.
Hello.
How are you doing? All right?
Yes, good. How are you?
Yeah, not bad at all.
That's good. I'd missed the first session. Has that been going? That went well?
Yeah, we were just introducing the sort of general conference and going over the bits and bobs. So your talk, I think you're aware, is got CEUs available within. So we'll need the 2 keywords at 2 intervals throughout. I'll try and remember to remind you.
I'm terrible with things like that, but I will do. Yeah.
We've got lots of folks here who hopefully can help as well. So
keep me on track once I get into my flow.
Yes. But yeah, we'll give folks another minute or two just to.
Brilliant. I might just share my screen actually, if that's okay, just to make sure it's okay. Give it a go before they.
Maybe have I enabled it? Let me just make sure I can allow you to. There we go. I think it should work now.
Brilliant. Yes, it does. Excellent.
Fabulous.
It's always the bit you want to happen, isn't it?
Yeah, getting some of the technical bits. Definitely. Well, should we make a start? I expect people will kind of trickle in as we sort of go through things, but if we make a start and hopefully everyone's aware, if we're doing the sessions, it'll be obviously up to Laura at the end of it whether she's happy for it to be popped on our website, but we've kind of just set it as default that it's videoing. All of you folks who are here as participants, you can interact via the chat and ask questions using the question function. The question function is the best function to use if you've got a specific question, because things in the chat tend to sometimes get a little bit lost in that sort of narrative as people are discussing things. So do use those functions. And we'll have some time towards the end, Laura, hopefully for some questions rather than go through. We'll sort of leave that for the end of the session, if that's okay.
Absolutely, that's perfect.
And I'll put myself on mute and be listening, but when we get to sort of round about the halfway mark, I'll just prompt and see if there's a keyword we can add for the CEUs.
Fabulous, thank you.
Fabulous. I think that's everything, isn't it? Thank you so much, Laura, for coming along and agreeing to talk at our conference. I'm really looking forward to hearing all about this. I'd like to begin with a bit of an intro and go for it when you're ready.
Lovely, thanks, Hannah. Hi, everybody. Obviously, people listening now and people that hopefully can join and enjoy this at a later date. I'm Laura Higgins, and I am a Board Certified Behaviour Analyst, and rapidly, I suppose, becoming a UK Behaviour Analyst cert. I've worked in different settings, so community and health and social care. But I suppose the part of my career that I wasn't really preparing for was when I worked in a secure forensic service supporting adults with an intellectual disability and learning disability, and really understood how environments can impact on positive behaviour support. So I think for me, it's about understanding things in the system, and this particular area was where that really tested that. So that's a little bit about me. And I think I'll dive right in because I think it's good. I really want this to feel that people, because it's not a big research area and it's very much about small areas of people working in practice, I think it'd be really nice to have some time at the end to really sort of chat things through and hear other people's examples. This is by no means the font of all knowledge in this area. It's just a scratch on the surface, really, because it's such an underdeveloped area. So yeah, hopefully you're all here because you want to hear me talk about PBS in a secure and forensic service. And we're going to talk about the current research in ABA and positive behaviour support in forensic settings, some of those challenges of applying positive behaviour support in such settings, and then give a practice example of using PBS to support restraint reduction in a unit for offenders with an intellectual disability and or autistic individuals. And, you know, some people with a diagnosis of learning disability and or autism who offend require support for behaviours that bring them into contact with that criminal justice system, and for other behaviours described as challenging. And what we mean by that is that, you know, people might have found themselves in a secure setting or a hospital or prison, but on a day-to-day basis, it might not necessarily be the offence or the index offence that's actually causing sort of those management or support issues for the staff and people supporting them. And as we are all pretty much aware that, you know, secure settings can present challenges for those who are detained by imposing those limits on personal freedoms and upon opportunities for development and growth. So one of the things we know is key about positive behaviour support is really thinking about, you know, skill building and developing people's worlds and expanding that, and really that emphasis on quality of life. And obviously the environment itself is a challenge in secure settings, and that restriction and those use of restrictive practices might create those conditions under which challenging behaviours are more likely, which seems really obvious. But I suppose what we're saying is those capable environments haven't been there as a sort of prerequisite to the work that we would be doing. So in terms of the current research, there's lots of information and research on prevalence. The treatment has mainly focused on sex offending, and CBT, or cognitive behaviour therapy, and dialectical behaviour therapy are those dominant treatment approaches that you'll find in the research. So not necessarily around positive behaviour support. There's very little research in that area, especially around that assessment and treatment of offenders with intellectual disability and autism. When you look specifically at the applied behaviour analysis literature as well, it's quite sort of scant on this topic. So if you look at the Journal of Applied Behaviour Analysis, there's only 9 articles, and they're again focused on sex offending, and treatment for other offences such as fire setting didn't produce any articles. So there's a very small amount of research. Give me a second just to move far up here. Okay, give me a second. Close that there. That's it. So this is really interesting. So the systematic review that was published last year in 2021 by Collins, Barno and Baker was really interesting, and they looked at only 11 met the inclusion criteria, which were published between 2005 and 2019. And for people interested, the inclusion criteria was that it was published in English, that they included empirical research, so that was published and unpublished, and that included a primary and secondary data set. And the focus of the research was conducted in forensic settings, and the definition included community, secure inpatient, probation services and prison. And 5 of those studies involved service users, or people we support as participants, as opposed to the staff and carers that were supporting the individuals. 3 out of the 11 cited challenging behaviour, or, you know, behaviour of concern, as the independent variables, what they were looking at. And these 3 studies indicated positive outcomes for the positive behaviour support interventions. 2 were single case designs, so looking at one person with a learning disability. And some of the articles by Davis et al. That were published in 2019 showed significant improvements on measures of aggression and other challenging behaviours, and they were reported to be maintained over that 12-month period. So they did have those gains and were able to be maintained. Findings of the current review highlighted that limited research has been conducted in this area, that the studies included had a poor methodological quality. However, the evidence does show that behaviour analysis techniques have been implemented within forensic settings with some degree of success. There's several challenges to implementation were highlighted, which I'll talk a little bit more about with the case example in a minute. And PBS interventions that inform staff about antecedents and causes of challenging behaviour are more likely to have a positive impact on the care and treatment of individuals within forensic settings, which kind of goes back to the original point that it's not necessarily or just the focus on treatment around the forensic index offence, but it's actually all of the other stuff that supports people on a day-to-day basis. Studies that were included in the review had limited follow-up of individuals within a PBS framework, and therefore that long-term impact of a positive behaviour support approach had not been explored. The researchers said that, looked at what future research should focus on, and that was exploring reduction in numbers of challenging behaviour, reduction in the number of restraints and seclusion, which we all know is really, really hot topic in terms of all the CQC publications that are in this area for inpatient units. Quality of those behaviour support plans, often they look like risk plans in inpatient settings, how to manage behaviour once it's occurred, as opposed to sort of that preventative positive approaches that we might associate within a PBS framework. Recidivism, which is the likelihood of reoffending, the length of stay for people whose care and treatment has been informed by a PBS framework. And again, really, really key, because when people find themselves in these settings, one of the key aspects is to ensure that they're there as short a time as possible. Often, there's quite a hot topic at the minute, and lots of information that you can look at around the review of the Mental Health Act. There's some concerns over whether actually some of the definitions of change in what a mental disorder is and where people with intellectual disability and autistic individuals fit might actually in some ways work against this and perpetuate a longer stay in hospital. So it might be worth, if you're interested, having a little look at some of the information and review around that. So why would we, apologies, why I keep going too quickly. So as we said before, it's that day-to-day support, why we need to think about PBS in forensic settings. It's the everyday support that's really what becomes the sort of high concern for staff. There are often environments of high stress and burnout for staff as well. High rates of violence and aggression, you can normally get that through the NHS data that comes out every year. And you're looking at sort of 450,000 roughly incidents of where staff have received some injury through an incident within these settings. And traditional interventions in forensic inpatient settings have historically emphasised that control and management over treatment, and we've all seen some of the problems that we've seen off the back of that. And to support the reduction of restricted practices and improve those individuals' quality of life, now talking a little bit about sort of blanket restrictions, which are the kind of given in some of these settings that can actually really impact on an individual's quality of life. And we've seen those high profile cases of abuse and overuse of restraints sort of in those traditional areas such as sort of Winterbourne Review, which is more of an assessment and treatment, but there's also Shaney's law in the case where somebody that went into a mental health unit for treatment actually died as a result of an overuse of restraint. So looking at the journey to transform a service, I'd like to just spend a little bit of time looking at a little bit of a case study now. And again, loads of questions at the end, please ask them, because I haven't included everything here. And this is very much about just one service. So, to err with caution as we go with it, but hopefully it'll give you a flavour of how we started to think about using positive behaviour support and restraint reduction in a unit for offenders with intellectual disabilities and autistic individuals.
Would this be the time for a keyword, Laura?
That would be perfect, thank you. Shall we have secure?
Secure.
Keyword is secure.
So first keyword is secure, folks. Just to let you know, I'm having a bit of trouble chatting, actually interacting with people in the chat who've asked questions. So I will cover anything that people have put in there around some of the logistical bits and bobs. But just to let you know, I'm not ignoring you if you've asked a question to me. It's just being a bit.
Yeah, no, I'm going to try and leave loads of time for people to ask away.
And the question and answer feature will be good to use. So sorry, Laura.
No, go ahead. It's nice, yeah. So so the service profile, just for thinking about the background, was 4 wards. It had 1 medium secure, 1 low secure locked rehabilitation for people with acquired brain injury and intellectual disability, and autistic people were potentially included in those wards. The focus of this is the 1 locked rehabilitation for the autistic spectrum conditions that again had people with intellectual disabilities that lived there. They were aged 18 and over and were detained under the Mental Health Act, and that was based in the northwest of England. So the team had a board certified behaviour analyst, which was very exciting. That, you know, to have that resource, I suppose, within that MDT that wouldn't be usual. The consultant psychiatrist, intellectual disability and mental health nurses, which I think was a really good blend of having both perspectives, which again I'll talk about because it actually became a really powerful support to have those 2 practitioners there. A positive behaviour support practitioner, an occupational therapist, therapy assistants, speech and language therapist, and registered behaviour technicians. So before PBS, you can imagine it was a very high stressed area, that restricted practice were used as that first resort and not the last. There was poorly trained staff, not necessarily that they didn't have any training, but it was in different areas. So people would have a lot of training around what was managing violence and aggression, which was the physical intervention training, which predominantly looked at sort of how to use the physical skills and not very much about proactive. Predominantly the medical model of care was the dominant model, and there was a high use of sedative and antipsychotic medication in use. The environment particularly was very sparse and limited access to therapeutic activities. People did not do very much at all. And just to give you an idea, this was one quote that I think gives you an idea of where people's understanding of that behaviour sort of function was very much in that sort of, they're doing things to wind me up, people are manipulative. There was not very much sort of curiosity or understanding of the function of that. There was limited positive risk taken in meaningful activity for most individuals. Using the service was low. There was mainly reactive strategies, and no one had a positive behaviour support plan, only risk management and reactive plans. There was negative language frequently used, which was, you know, about the people as well, you know, why they were there. Perceptions of the service was negative. People were fearful of the service, and as a result of also of the people who used it and people who lived there. I suppose from an organisation point of view, there was very significant impact on staffing levels in terms of high burnout, staff injury and turnover. And the staff service lacked focus and strong leadership to enhance that quality of life for patients and for staff. So it's quite a big challenge to be faced with. So thinking about, I'm sure you've all seen this, but the periodic service review was very much used to start to think about what we needed to do within the service for that total change. And it was used, the periodic service review uses positive behaviour support, total quality management and organisation behaviour management. And it takes that aversiveness of management away. It's a bottom-up approach. Everyone wants to do their best, and it's one system for everything. And this enabled the service design and delivery to meet best practice guidance and recommendations. It helped frame those goals to provide feedback, which was really essential on progress towards accomplishing the goals that had been set. And PSR data showed consistent improvement over time in areas targeted for intervention and improvement. And it's really important because then it gives plenty of opportunity for positive feedback for staff. But then if things weren't progressing how we wanted to be, to really include the staff team and the MDT or the multidisciplinary team about what we needed to do to change that in order to meet those goals over time. So we did have an overall strategy that was designed and overseen by the Board Certified Behaviour Analyst. I'm in trouble with my words today. The plan was implemented over a 2-year time frame, and the interventions and data collection were targeted at 3 levels. So that was at the wider organisation, the service level, and at the individual level as well. And the outcome and monitoring data was collected and analysed by the BCBA, the assistants, and the wider MDT. So to get started, having that behaviour specialist employed in a strategic position to make change was quite key and quite innovative. So instead of sitting outside in just the clinical team, the the behaviour specialist was also in the operational decision making, which I think was actually key for this to actually change, to be able to have that oversight. The baseline measures in key areas such as restricted strategies and quality of life, etc. But organisational buy-in, I don't need to, it's like preaching to the choir, but ensuring that the organisation understands this, provides the resources, and spending that time to make sure that that was in place was really key. Winning hearts and minds, you know, getting people to think about people being people. I think, you know, we struggle in lots of settings with this, but particularly if people have, you know, perhaps an offence that's uncomfortable to people, that can be even more difficult. And then getting the environment right, the sort of social and physical. We had to look at what people's training needs, analysis, what they were already getting, what they needed. Very simply, you know, one of the interventions was looking at moving physical intervention to include proactive strategies, and just doing that alone. So flipping the having the physical skills at the beginning of the week and all the positive skills before people went into service was actually had a reduction in use of physical intervention just by a very small shift in the training. There was a workforce development plan for all levels of the people that worked there, securing those resources, and there really needed to be that commitment and energy to make positive change. This does not work if you don't have leadership and a team of leaders that really are committed and energized, because it's really quite a tiring process to think about all of these things and to really, I suppose, change culture. PBS awareness sessions for staff, service users and families. So families up until this point hadn't massively been included. They were, you know, they were seen almost at the periphery, or sometimes even the problem, maybe in some cases. And then obviously writing the PSR for the service. So this is the priority analysis. Won't kind of go through more, but just really quickly, really key, looking at there was no communication strategy. So the speech and language therapist was absolutely instrumental in thinking about what is it that we needed. People need to communicate effectively. That medical model I've spoken about, and that the culture identified in staff interactions was not supportive of PBS. Physical environment was just dire. Don't need to go into that. It was really, I think, low stimulus became almost no stimulus. I think it was well intentioned to start with, that, you know, it had to be sort of low stimulus, but actually that didn't quite translate. Staff training and awareness was, as I've said before, in physical intervention. Nobody'd even heard about PBS. There was no functional understanding of behaviour. Service-wide restrictions or blanket restrictions were there, so everybody could only have, you know, 10 CDs. Only people could have certain times where they ate their snacks, and high frequency of physical intervention. There was no data being collected on whether people's lives were good or bad or indifferent, and there was no plans in place, and certainly no evidence of skill building. So the PSR data, I mean, these slides I think will be made available, or I can email them to you because that's quite small there. And Hannah's nodding, so I think you'll get them. At 6 months, you know, you can just see that lovely upward trend, which is what we wanted. I think with the PSR, you're looking at 80% and above to be confident that things are kind of going in the right direction. For people that are interested there, these are the kind of data we were collecting in terms of at the organisation level, so that not only were plans in place, but were they of any quality, number of restricted practices, that the individual at the service level, and that they were being reviewed. And then sort of really important, thinking about staff sickness, retention, and those number of supervisions. So were staff getting the support that they needed? With the physical environment, we used the positive environment checklist, feedback from staff meeting. You know, people might be aware of PBS Academy, what PBS looks like, observational toolkit, those individualised quality of life tools, individual feedback, and then a number attending training. So the barriers, obviously very resource intensive at the beginning in terms of the physical environment and recruitment and training of staff. Consistency of staff approach was a problem at the start, and improved when staff had more training and less use of agency staff, because it was such a big service, and it was, you know, going back to all those issues, people didn't really want to work there. It was very, very few permanent members of staff and a high use of agency staff, so it was very inconsistent. There was a resistance to change, and people thinking it would increase risk by adopting this approach, so that things would be more likely to be dangerous, because we're sort of those words that you hear, like giving in to people, or, you know, why would we let somebody out an hour after an incident because they hurt me? But actually, if we knew that that individual was just really sensory seeking and just needed to be out in the fresh air, that took a lot of time and a lot of support to make that happen. The medical model was a big challenge. You know, these services are set up very much with a psychiatrist that run the MDTs, and it takes a long time to think differently because of the way that the culture of how things work and operate. But when it does, when it all comes together, it's really positive. So embedding positive behaviour support. So following that initial implementation and rapid change, the focus shifted to embedding. So this was between the sort of 6 and 12 months. The data collection continued and observations. Every service user had a PBS plan, which was regularly audited using the evaluation tool. Nurses were all trained in functional behaviour assessment, because obviously they are on the wards more often. But this was key. The recruitment of a PBS practitioner who was put on the MSc in Applied Behaviour Analysis, so there was somebody able to very much be there all the time, keeping an eye on everything. And improvements to the physical environment continued. Speech and language supported a total communication environment. Cannot understate that enough. You know, I think very much if you've got other allied professionals that can work in it within a PBS framework, it's absolutely key to the overall outcome. The individual restrictions were reviewed, so no longer was it okay to say, one that sticks out was that normally Section 17 leave, which is just the ability to be able to go into the community, was standard 24 hours for everybody after an incident, and it was almost becoming impossible for some people to ever leave, whilst not really recognising that the environment was the reason they were struggling. So that was reviewed as one example. Service-wide restrictions we've spoken about, they were very much identified and reduced. Focus on quality of life was measured, involving service users in their PBS plans, but still had a long way to go, but there was some attempt at that. Visible presence of behaviour specialists on the ward, and functional-based intervention plans were being trained so staff could implement with fidelity. So staff understood why they were doing what they were doing. And this is where we were after 2 years. So we had staff turnover had reduced from 28% at baseline to 19% at 2 years. And staff retention, which is what we wanted, had increased from 75% at baseline to 89%. The number and intensity of incidents had reduced. Everybody had a plan with skill building and engagement plans included. And I think the key shift here was having the therapy team based within the service. So there was OT and speech and language within that PBS framework that enabled really good, meaningful activities. Restricted practices were reduced, most noticeably in the area of physical intervention. Families, commissioners and people who used the service gave positive feedback. So this service wasn't open to referrals, and then we had a waiting list by the end of this, and was really recognised to support that ongoing discharge of people, because often places which we know stay silted because there isn't sort of effective, robust kind of community provision. So, you know, that's where we you end up having people stay in hospital and secure units for longer. Physical environment had improved, and the overall quality of life for staff and people being supported was also improved. So this is just the people that like the graphs. You know, there was only 20 people based within this one ward. And if you look at the kind of high numbers of restraints in those baseline going down to the where we wanted it to be, really. People always ask as well, did other things go up? So, you know, we have less physical intervention, so therefore, did we have more use of sort of chemical restraint? And we didn't take lots of data on that, but for the couple of case studies that we did have, we found that was not the case. So again, maintaining it, we use practice leaders extensively to bring out and sustain change in line with best practice. Practice leadership allows for those specific interventions to be adopted responsibly to change in situational context. And by that we mean people are simply there. You can't do this by remote control. You can't have the MDT and the clinicians detached from the everyday sort of support systems that go on. And I think we learned, well, we've seen that things definitely deteriorated, and we've got data to show therapy, present on the ward, good outcomes. From afar, not so much. it seemed that service change would be compromised if managers and clinicians were remote from that behavioural and social culture to change. And I think, staff or colleagues very quickly will say, well, I'm not doing it if you're not doing it. You're not here all the time. When all of those barriers were broken down because we were there. And then limitations and next steps. Obviously, it was a project, and the data was collected and analysed in-house, so it wasn't independent. I think, if we're to really think about next steps of using PBS in a forensic setting, we would have to have that evaluated independently. Some data collection tools relied very heavily on the clinical judgment of the administrator, so the people that were sort of, I suppose, in the moment, which could have a positive effect but isn't objective necessarily. And then that further exploration of the use of positive behaviour support for other vulnerable groups, such as those with acquired brain injury and female offenders, could also be explored. So for PBS to be successful, it required the behaviour consultant working collaboratively within a clinical team. So, being really kind of part of that MDT, that everybody had an understanding of the functions of behaviour, and that included that the housekeeping team that used to come on the ward were able to fully understand, within the limits of their role of what we were trying to achieve. Skills-based programs, so that we weren't just minimizing behavior, that people were gaining skills to be able to have a better life. Robust data collection to monitor that change. We had to be able to evidence it and know where to change it. That explicit culture and value base, we had to be really, really clear, and that people, if they weren't happy with that, had to really think about how they fitted into that new way of working. Resources for the physical environment and skilling up the workforce. People always say, well, we can never release staff for training. So one of the things we did was have bite-sized training sessions that were short 15-minute sessions that were built up over, weeks on weeks of different topics. And that was really, again, when you think about support and commitment from the wider organisation, other members of the MDT would come and take on those observations and support of people, whilst frontline staff could go and have those sessions. PBS in this forensic service has been well received and has gone some way to provide evidence that it can be implemented in a secure setting. So we're pinching a bit of a quote here from John Taylor, and the challenge of those who advocate for the use of PBS in forensic settings are to define more precisely what PBS compromises of in this context. So because we haven't got clear definitions of what positive behaviour support is in this context, it's very difficult then to replicate. So we'd have to clarify what training and supervision is required to ensure its safe and effective implementation, and to develop the evidence base to justify its use for people with learning disabilities. So I suppose this case example very much focused on the support in the everyday to minimise those behaviours of concern. Okay.
And we need another keyword as well, quickly.
Oh, we do. Let's have practice leader.
Practice leader.
Yes. And then if anybody wants to, this was a special edition in the International Journal of Positive Behaviour Support that very much tried to start this conversation about PBS in forensic services. So it has the case example in more detail that I've spoken about today, but it also has the full systematic review and different articles around sort of forensic issues that might be of interest. But again, just to signpost you there. I'm also happy that in my current role, there's my email. I'm head of positive behaviour support, so that's my current work email. You're more than welcome to send any questions that you've got to that email address if we can't answer them here today.